right, welcome back. There is absolutely no better way to end this day than to have Dr. Judy Salerno and Dr. Don Berwick close us out. They have both done incredible work in this space, and the New York Academy of Medicine has been an excellent partner of ours. And I'm honored to turn it over to Dr. Judy Salerno to share a few words.
Thank you, Aaliyah. You heard a lot today about the social determinants of health and why civic engagement matters. So let me add my voice and that of my organization, the New York Academy of Medicine, to that chorus of support. It's critical that we not only stand up for the right for everyone to live their healthiest life possible, but that also we find innovative ways to influence policies that affect health and well-being. And we have to further facilitate ways for those who shape the policies that affect the lives and health of all of us to share their power and privilege. Civic engagement is fundamental to that way forward, to shift power to communities who know what they need and can show us what's lacking, and things that will allow them and their families to live their best lives. I remember the old adage I learned in medical school that if we listen to the patient, they'll tell us not only what is the matter with them, but they'll tell us what matters to them. That's honoring personal and community voice. Addressing the social determinants of health, including civic engagement, are critical levers to adjust society. When we raise the voices of all, it can determine how we navigate a future that is not preordained by where a person lives, the work they do, how they worship, who they love, or the color of their skin. At the New York Academy of Medicine, this guides our work as we seek to advance health equity. We know we can do better, and we know we must do better. That's our North Star. I'll now turn this over to Alistair to introduce the keynote speaker. I'm thrilled that you'll now have the opportunity to hear from Don Berwick as an outstanding thinker, a wonderful human being, and a longtime colleague, and someone who's guided many of us to that North Star. Thank you.
Thank you so much, Dr. Salerno. You know, the New York Academy of Medicine has been really from the beginning of its inception, to be honest, focused on the important matters of health equity and working on issues around the social determinants of health before they were even called the social determinants of health. So thank you so much, Dr. Salerno, and to the great work that you all do at the New York Academy of Medicine. It's now my honor to introduce the final closeout speaker of the day. There is a historical figure that many of you know, Dr. Rudolf Virchow, who really stood at the nexus between medicine and policy and politics centuries ago, but really laid the foundation for a lot of this work. Dr. Virchow says, medicine is a social science. Politics is nothing more than medicine on a large scale, and that the physicians are just the natural attorneys of the poor. I'd amend that to say that nurses and the social workers and medical students are also those natural attorneys of the poor. Nobody understands this better. Trust me when I say this, nobody understands this better than Donald Berwick. Donald Berwick is the President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, an organization that he founded. He's also a former administrator of the Centers for Medicare and Medicaid Services. He's a pediatrician by background, and he served on the faculty of Harvard Medical School, the Harvard School of Public Health, and on the staffs of the Boston Children's Hospital, Massachusetts General Hospital, and the Brigham and Women's Hospital. Dr. Berwick has authored or co-authored over 160 scientific articles and 6 books. And he currently serves as a lecturer in the Department of Health, Healthcare Policy, and Policymaking at Harvard Medical School. I want to just go off script for a second and just come back to the personal impact that Dr. Don Berwick has had on my life. it was a big leap to decide to leave medical school for 2 years to go off and get this master's in public policy. Before our year, there really weren't many examples of people who had taken time away from their medical training to go and study government and policy. And Dr. Don Berwick, for me, was really a guiding light. It was his path and the incredible work that he had been able to do with that degree and with that time and energy and expertise that he got from the Harvard Kennedy School that compelled me to make that leap of faith. And because I was able to make that leap of faith, I've been able to engage in work like this and have been able to do this incredible work with an organization, a team of really exceptional people. And I thank you, Dr. Berwick, for just leading the way and demonstrating truly the importance of this intersection between medicine and policy. Thank you, Don.
Well, thank you, Alistair. Thanks, Judy, and the New York Academy, and this conference. Is just such a privilege to join you. I feel blessed to have you among my friends, and I'll try to be helpful. You've already had exposure to most of what I want to share with you, so consider this last session of your day, or nearly so, a bit of a review. But I do want to dig into some thinking I would like to share with you. The talk I'm going to share is a pretty personal one, in the sense that it reflects a journey of mine that's occurred over the past 3 or 4 years, and it ends in a sort of edgy place. I'll give you a little bit of warning, and I'm gonna have to go fast. I don't have a lot of time to share these thoughts with you, but it, as I say, hopefully it's a bit of a review. So the basics start with my career, which I'm a pediatrician, and I did practice, and I did, but I got very interested in quality of care at the beginning of my career, really, and had the benefit of tremendous colleagues, and eventually the chance to start a nonprofit organization, IHI, the Institute for Healthcare Improvement, where we continue to work on the scientific approaches to improving complex systems. And of all of the canons of that field of quality improvement, the first one is you've got to have an aim. You never improve unless you decide to. I'll never learn Spanish unless I decide to learn Spanish. Healthcare can never get better unless it decides what it wants to get better at. And we have now several decades of history of scientific foundations for aims. The pivotal point was probably the National Academy of Medicine report, Crossing the Quality Chasm, in 2001, which I helped to write, which you may know set out 6 aims for improvement: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Those 6 aims became kind of well absorbed into the American healthcare system. In fact, are used worldwide. I'm now working with the country of Singapore, for example, and they've taken these 6 aims: safe care, effective, patient-centered, timely, efficient, and equitable, into their strategic frame. In 2004, 2 colleagues of mine, Tom Nolan and John Whittington, faculty at IHI, came to me with a complaint. They said that basically that wasn't enough, that these 6 National Academy aims referred to what the care should be if you're in the care system. But they know, like you know, and have been studying in this conference already, that the generators of ill health don't lie in healthcare. Healthcare is a repair shop. We fix dented fenders. We don't actually work on the roads very much, but the roads are where the fenders are getting dented. And these community-based, population-based roots of illness, injury, and disability are actually the causal system. Healthcare treats the effects of the causes, and Whittington and Nolan posited the healthcare aim should include the causes. We should be moving upstream to improve health of populations, improving the experience of care for individuals when they're in care, and improving health of populations. And the third part of this triple aim became reducing waste, so that we're not wasting energy, and then we're reducing per capita costs, so actually resources are left over to improve communities in public and private hands. That's the triple aim. And if you stopped me a few years ago and said, what am I working on? I would have said the triple aim, or maybe I would have said this: if we're having proposals like to an Affordable Care Act, or a proposal for a public option, or you name it, how would we know if it's good? And the answer is we know that it's good if it advances the triple aim plus universality. And so, in my head, if you woke me in the middle of the night and said, what are we trying to get done? I'd say four things: make healthcare a human right, improve the quality of care, safe, effective, patient-centered, and so on, improve the causal system, the population health, and reduce costs at the same time. And a modern view of aims in healthcare would be these four things, in my view. Always contextualized today, of course, in the COVID pandemic, and also in this surging new wave of rhetoric, at least about structural racism and the wake of the George Floyd murder and the murder of others, and the continuing problems we have as a heritage of slavery in our country. The COVID pandemic has changed that a lot, or it's added stuff. In a paper I wrote in JAMA last year, I tried to analyze what choices is COVID bringing us, and these are some of them. Breathless speed. We're now able to learn and change much faster than we were pre-COVID. We've adopted tempo that I've never seen before, and we could use that in the future if we want. Go faster to make changes. We've adopted more standardization, learning how to do better. I was talking to Judy Salerno when we were waiting in the green room just now, and she was talking about the learning process in clinical care, about how fast we're learning standards of care. We know what we need to do for COVID patients. Virtual care, of course, and virtual everything, such as my speaking to you right now, causing us to reconsider habits and legacy behaviors around encounters, visits. What's the new form of relationship to the people who come to us for help? Protecting the workforce, I'll come back to, but we got caught on our heels. We did not protect the workforce. They and the country paid dearly for that, and we have a chance to learn from that and adopt a much more capacious view of what the workforce is and what they need in order to do their work with joy. Preparedness itself could be a topic for another lecture. We were not prepared. Hopefully we're learning that now, and we're learning how to be better prepared for future threats. And then inequity, the topic largely of this conference and of the rest of my remarks. COVID asymmetrically hurt people who were already at disadvantage, including people of color in our country. One point I want to make as we dig more deeply into inequity is that the inequity problem that we're going to talk about for the next few minutes, it's not just out there, it's in here, it's in the workforce. One of the new sensibilities, I hope, in the American healthcare scene is the idea that the workforce is also vulnerable and subject to the same consequences of racism and poverty and othering that other segments of the society are. This article appeared in May of 2020. More than 800,000 healthcare workers and 1.1 million of their children live in poverty across the US. They work in healthcare, but they're paid so little that they live below the poverty line, which is a very stringent line in our country. Our poverty line it's very stingy. About 18 million people employed in healthcare, 10% of them earn so little that they get healthcare through Medicaid. And 1.4 million health workers, as of this article, had no health insurance. So we've got no business pointing fingers at a society that is not dealing with people who are vulnerable when it's happening right in our own quarters, of course. You've been talking, and I will now talk about the vocabulary for dealing with the causal system, the social determinants of health. And just at the risk of too much repetition, I'm going to use briefly the work of one of my heroes, Sir Michael Marmot, whose book, The Health Gap, is mandatory, ought to be mandatory reading. I think every student of medicine, nursing, pharmacy, health administration should read The Health Gap. What Marmot did, a world-class epidemiologist, was in 2015 assemble the literature on what creates disparities in health, not just among countries, although he does that, but within nations as well. And so Marmot offers a very efficient vocabulary for social determinants, the stuff that I'm sure you've been talking about in this conference and will continue to. Marmot's digest of the available research says that there are 5 social determinants, 5 pots of social determinants. Here they are. The experiences of early childhood. I'll tell you more about that in a minute. The state of a country or a region's education system, whether it's high achievement and supportive of everyone. Conditions in the workplace, including minimum wages, as well as workplace conditions like exposures to toxins or maintenance of a meaningful workplace, one where respect and dignity are ambient. Experiences of elders, these are whether nations or regions invest in reductions of isolation for their elders. Nations supporting elders to remain connected to society and to the workplace if they wish. And then a whole potpourri of things, community resilience, which most people would think of as the social determinants, food security, housing security, transportation, environmental threats, criminal justice, violence, recreational opportunities. It's sort of community capacities. Marmot goes in his book through enormous amounts of data showing a couple of things. One is that these are powerful causes of illness, injury, and disability, that they vary greatly among and within nations. And particularly in the United States, we're not doing so well, that there isn't any one of these 5 categories where we're anywhere near the top of developing countries. And in many cases, we're at the bottom of rankings for OECD or comparative structures. We don't defend our children, not across the board. We don't have the top performing education system in the world. We're rather median overall on average. Some is great, but a lot isn't. Our workplaces are not defended the way the conditions of workers are elsewhere. We don't have an elder care policy in this country. And our community infrastructures, transportation, housing, and so on are much more frail than in a lot of other developed countries. Marmot adds a 6th determinant, which he calls fairness, which he posits is the cause of the causes. That is, behind the variation among nations or civil societies or governments with respect to their investment in these causal systems lies an underlying feature, which he thinks is a sense of solidarity, a sense of mutuality, a sense of responsibility for each other. He summarizes it in his book, which he actually repeats this several times. Inequities in power, money, and resources give rise to the inequities of the conditions of daily life, which in turn lead to inequities in health. Inequities in power, money, and resources, inequity, give rise to variation in social determinants of health, which lead to the variations in health that Marmot is studying. The consequences are dire. In our country, for example, Raj Chetty's amazing work shows here, for example, the relationship between household income and expected age at death, given that you've reached 40 years of age. For people who reach 40 years of age, their expected ages of death vary very strongly with household income. Look at the differences here. At the very lowest to the very highest levels, women between the bottom 1% and top 1% have life expectancy differences of a decade. For men, it's 15 years. The consequences of the social determinants, manifestations of investments in equity, are dire. I want to dig for a minute a little more deeply into the child health component. I'm a pediatrician. I'm the father of 4. I'm the grandfather of 8. I care a ton about kids. And actually, last December, the Surgeon General in California produced this very, very important and replete report about social determinants in childhood. One of the indices, is our adverse childhood experiences. It's a bit problematic because it's a deficit view of the conditions for children, and we're learning, I hope, more to look at assets as well as deficits. But if you study children who are exposed to adverse childhood experiences and track them through life, there is a very strong relationship between this ACE score, which was developed by CDC and Kaiser Permanente. It's simply a count of the number of serious stresses kids get exposed to, and adult health status. Look at this. For people who as children had 4 or more ACE exposures, twice the rate of heart disease, more than twice the rate of cancer, much more than twice the rate of accidents, chronic lung disease, stroke, mental health conditions at double-digit multiples. Adverse childhood experiences strongly affect the conditions of adults with respect to health and longevity. Michael Marmot's social determinant at work. You can take a disturbing look at this through the eyes of the so-called Child Opportunity Index. This is a rating scheme developed by a multi-institutional consortium, multi-university consortium, which basically takes every single census tract in the United States, about 70,000, and scores them with respect to childhood opportunity, by which they define with these variables: the educational opportunities and condition of kids, the health and environment of children, supports to health and environmental threats, and then social and economic well-being. It's a complex index which scores every single census tract in the United States. It then allows them to score neighborhoods or census tracts with respect to this index. To give you a peek at it, here, for example, I've got two neighborhoods, A and B. Neighborhood A would be a low opportunity area, and B, a high opportunity area. So neighborhood A has a higher poverty rate, much less availability of early childhood education opportunities, much less green space, much more food insecurity, much more housing insecurity. If you take the United States, those 70,000 census tracts, and you ask where do kids live, this is what it looks like. White children, for example, living in census tracts, here you're looking at the quintiles of census tracts from very low opportunity to very high opportunity. And white kids and Asian and Pacific Islanders are living about 40% in very high opportunity areas by those indicators, and about another 20 to 25% in high levels. Most kids, white or Asian and Pacific Islander, are living in high opportunity neighborhoods. This is the same distribution for Black and Latinx kids. For Black children, 46% are growing up in census tracts of rated low opportunity with respect to the indicators you just saw. Let me show you how this looks in a somewhat more vivid way. From their website, this is the Baltimore metropolitan area, showing where kids, we're going to show where kids live. Each census tract is coded with a color code from very high opportunity to very low opportunity in this area near our nation's capital. And here is where white kids live. Every dot is 20 children aged 0 to 17 who are white, mostly living in areas of high or very high opportunity according to that index. And this is where Black children live. African-American kids, every dot is 20 African-American kids living in areas of much lower opportunity as indexed by that scheme. I think you already probably know, if I were to show you the map of this area with respect to redlining in 1950, or other indicators of failures of social investment, it's the same map. It's the identical map. When we talk about structural racism, this is partly what it looks like, which is having created conditions more than a century ago, in which people of color are subjected to stresses and policies that are injurious, that has carried over into structures like this today. Now, the consequences you've been studying in this conference and know well, which is that there are morbidity patterns which reflect these differences in social determinants, more than double the rate of infant mortality among Black newborns in this country, and double also for Native Americans, for example. And in the COVID pandemic now, of course, we see the same thing. The burden of this pandemic on people of color, as you well know, is quite a high multiple of that on people of more economic advantage in the country. Now, everything I've just, one more thing I want to show you. The consequences of these effects are not small at all. Here I've taken this is a subway map of New York City. Here is Midtown Manhattan, I think that's 96th Street, where the median income is about $180,000 a year. Mostly white, not many kids born into Medicaid. A few miles north on the D train or the number 2 train, I'm not sure, you're looking at the South Bronx, with median income less than a third of what it is in Midtown Manhattan. Many more kids born into Medicaid, and a much higher proportion of people of color. And the differences of health status are profound. Life expectancy difference of 10 years between those two subway stops. If you travel on I think it's the D train from here to here, you're losing about 2.5 years per mile traveled, 6 months for every minute on the subway. Those are massive effects. I decided to do a little illustration of how big the effects of these social determinants is. 2.3 years for every mile traveled on the subway. Let's take a look at a medical miracle by comparison. Medical miracle statins, right? half the people listening to me are on them. One of the most commonly prescribed meds in the country. Tremendous amount of research on statins. This is a paper by Christensen and colleagues in the British Medical Journal, Open, in 2015. And they asked the question, what does the literature say about statins? And without going too deeply into it, and remember, I'm a pediatrician, not a cardiologist, they determined that the most favorable literature on primary prevention trials using statins suggests that when you take statins for 20 years, you add about 20 days to your lifespan. It's about a day of lifespan added, according to the most favorable primary prevention trials, for 20 years on statins. That's a breakthrough. In fact, we score the quality of care with respect to whether people are on statins if they have elevated or borderline cholesterols. 20 days of lifespan is what you lost on the D train in 7 seconds of travel from Midtown Manhattan to the South Bronx. It's not actually a ramp, it's a cliff. You don't lose that every 7 seconds, but you reach areas where these conditions of inequity have led to changes much more profound than the medical repair shop addresses. If you're in the Glasgow bus and you ride from rich to poor Glasgow, you lose 20 days of lifespan every 43 feet. The consequences are those you're studying in this conference. This is the life expectancy for men who reach age 50 as a function of the year they were born. These men were born in 1920, 1930, 1940, 1950, and this is their expectancy, their life expectancy, given that they've reached age 50. Tremendous gains for wealthy men in America, almost none for the poorest 10 or 20% of men over a 30-year period. And for women, there's actually been loss of life expectancy over that 30-year period for people in the women in the poorest 10, 20, and 30% of our country. The effects of social determinants on health and well-being are overwhelmingly greater than the effects of our repair shop. But the repair shop's where the money goes, namely $3.4 to $4 billion of money. And there's a puzzle here. The puzzle is that we've known this for decades. There's nothing I've shown you that we don't have scientific literature that goes back years and years, decades, before my career began. And yet we continue to sit with the evidence of the generators of ill health and work on the repairs, not the causes. And I have come to think of that as a tremendous social paradox, which is, it's really hard to understand, especially in a wealthy nation where we would have the option to do differently. Is it economics? Not in the big picture, because it isn't good for a country economically to have the rather mediocre health status outcomes that our country is experiencing at extremely high cost. It is, of course, economics for the current incumbent stakeholders, because the people in the current system in the repair shop are actually doing very well financially, almost all of them. And so that would be an explanation that the momentum isn't there for change, is more inertia than momentum. Is it racism? Possibly. We know that a lot of the social determinants, as I showed you in that Baltimore map, are very closely correlated with race. And I suppose you could make a interpretation that the reason we haven't worked on causes is because we remain a society that's structurally very racist. And we have to get out of that, unlearn it. That doesn't completely cover it, though, because the same afflictions of causes of social determinants, the effects of social determinants, affect everyone. They even affect, as you can see in the work by Raj Chetty, people of quite middle incomes and not of color. There's a screw loose here. We continue not to do what any man from Mars or woman from Mars visiting us would say to do, which is work on causes, not just effects. And we continue not to. And that's led me to the point I want to close with, I warned you, the uncomfortable place, which is I'm on a hunt for the energy. I'm on a search for the momentum, search for the guts to work on where the causes are. And I cannot find a reference point that works for me other than morality itself. It's just whether we do the right thing. Do we want to be a nation and a community which achieves health for us all, or not, because right now it's not. And I think we have to have that conversation. And that leads to an even more uncomfortable place, because let's say we said yes. Let's say that we had leadership and some reckoning around whether we want to actually invest in the causes because it's the right thing to do. What would we do? We'd do more than get everybody healthcare. This is a list of 7 elements of what I would call a campaign driven by the moral determinants of health and the science of Sir Michael Bartlett and social determinants. First is we declare the aim. The United States has stood aside from ratification of major human rights treaties that almost all developed countries on earth have long ago ratified. We have not ratified the Convention on Rights of Children. We've not ratified the Convention on Rights of Migrants and their families, the Convention on Rights of Women. We simply have not declared our membership in the large-scale human rights endeavors of the planet at its best. One of those rights is, of course, healthcare as a human right, and we don't have that. We're 30 million people short of that, even if you accept the 50 million people with insurance that they have, but even though it won't meet their needs. I think that the moral compass would point toward unequivocally healthcare as a human right, and stop enough already. We've got to stop beating around this bush and make it so. We would restore our leadership in the climate change world. You are reading, as I am, about the enormous evidence about the health consequences of climate change for us and future generations. And unfortunately, in the prior administration, we took a pass. We stood aside. In fact, went backwards. Now, hopefully, we're changing that. We would fix our criminal justice system. We don't have a criminal justice system. We have a criminal punishment system. And it does not benefit from the knowledge we have about restorative justice, alternatives to prisons, safe reentry of incarcerated people back into society. And it is, as you know, a racist system, a 7-to-1 incarceration rate for African Americans to whites in this country, 5-to-1 for Latinos. It's the new Jim Crow, as Michelle Alexander's important book points out. And 70% of the people in our criminal justice system have mental illness, mental health problems, or substance misuse challenges. We would end the policies of exclusion and the absence of a compassionate immigration policy in our country that the Congress has repeatedly run away from trying to solve that very difficult problem. We would end hunger and homelessness in our nation, 2 core social determinants. We have, I think, something like 40 million hungry people in this country today, 40 million people in food insecurity, and 17 million kids in food insecurity. And we have chronic homelessness to the tune of well over 600,000 chronically homeless people in our country, if you just take the most severest definition of homelessness. Why in a wealthy nation would anyone be hungry or anyone not have a roof over their heads? And the 7th is what you're really all meeting about in this conference, which is to use democracy properly, to use the evidence and to build our democratic institutions' agendas around the evidence of how one perceives and pursues health. And that means voting. It means participation. It means fighting against this legacy and current behaviors which would deny people the right to do what every democratic society should guarantee, and that is the right to participate. And I think that's core to this agenda. Social determinants, yeah, it's a big idea. It means working on things that really cause the harms we have. And we know what they are. We've avoided them for decades and decades. And I think it's time to call that question. Should healthcare do this? Absolutely yes. Absolutely yes. With 18% of the gross domestic product in our hands, with the prestige and the gravitas healthcare has, with the oaths we take toward health, I don't have a lot of patience for healthcare organizations or professionals to say, well, that's not my job, that's someone else's job. No, it is our job. And we need to do that in our daily work, in the way our institutions exercise their presence in our communities, and in our political activism to argue for and support the agenda of allocation of energies where health can be found. That is what I have to say, Alistair. I don't know, I think I've used more than my time. I apologize for going over, but it's a privilege to get to share these thoughts with you.
This was incredible, Don. As always, you you know how to speak at this intersection between equity and social determinants of health and healthcare, but also you speak from a place that's deeply rational, and doing this because it's the right thing to do is an incredibly important message and voice that you bring to this, and also the importance of keeping in mind that there's good data behind this, which thank you so much for walking us through that, Don, and really a pleasure to have you as always.
Pleasure's mine, Alistair. Thank you.